Full slide, okay?
Yes, it looks great.
Perfect. So thanks for the introduction. That was a really nice overview into the diagnosis. And actually, Dr. Desai usually steals a little bit of thunder, but I think actually gave a really nice overview. So I can hopefully jump into a little bit more of kind of some of the treatment ramifications, or at least some of how we incorporate what she discussed as far as standard of care. There we go. So really going to go overview the treatment. So this is kind of like just a bird's eye view to start with. So I think I think one of the biggest lessons to take from today is that, historically, maybe even 10 years ago, a lot of times treatment was quite one size, fits all. So, are you older or are you younger? And you're going to get this therapy or that therapy. This is really changing actually quite a bit, which adds to the complexity. But I really think ideally for most patients, they can have very much a personalized approach. So that will start with, where did the disease come from? Is this an AML, again, that's, de novo or just was a new presentation? First, did it come from patients who've had past therapies or past myelodysplasia? A lot of this really directly goes into all of the mutations that Dr. Desai just mentioned. I'll try to get into a little bit more specifics from a treatment perspective. And then we have to sort of make a choice. Do we go for an intensive therapy or an induction therapy, or do we go with a low intensity approach? This has historically, again, been based on age. Classically, if you're over 75 or younger with certain risk factors, certain medical conditions, you should go for intense, non-intense. Again, I think this is very much changing and likely will change continually over the next 5 years. Can we get away from giving high-dose therapy even to young patients who have AML? I think is an interesting question. If you do get induction, you then go through often 1 to several cycles of what's called consolidation chemotherapy. I'll talk about patients that will ultimately go to transplant or recommended for transplant, although this is also a sort of dynamic change. So historically, if you're good risk, we may try to cure you with chemo alone, whereas if you're intermediate or adverse, we try to take you to transplant as soon as you're in your first remission. But sort of even in the non-intensive side, a lot of patients actually over the age of 60 to 75 actually have had several 78-year-olds transplanted. So it kind of brings in what's that optimal first treatment. But if patients are fit, irrespective of age, we do think about transplant from the beginning. And then once we get to sort of relapse refractory, different therapeutic options, targeted options, cellular options. I think we'll hear a lot of this at our next presentation, from Dr. Caraway as well. So I'm not going to re-go into this. It's not just mutation, yes, no. Actually, the sort of ELN risk, and I'll comment on that in a moment, is a little bit more straightforward. It's actually a lot more complex. So it's a lot of times based on what mutations you may have together. One mutation in one sense may be more favorable, while at the other end may be more unfavorable. A lot of us are all thinking about, can we put you on a drug that is specific for the mutation that drives your disease? I've already seen some of the questions pop up in the chat in regards to this. And it may matter. So maybe you have a mutation, but it's a low level and you have all these other mutations. And so if you make that one go away, how much better are you going to get? That may, whereas if that is really the dominant mutation and you inhibit it effectively, maybe you'll get a very great response. So it's more complex than mutation, yes, no. A lot of outcomes may have to do with what mutations you have together. Ultimately, again, we do have these 3 risk categories. This is relatively recently updated, but may change again in the future. And again, I think one clear thing is it's really not one size fits all. So even if you're going to get that high dose chemotherapy, and I'll talk about it briefly, of 7+3 induction, a lot of times we're going to add another drug. So do you have a FLT3 mutation? That may be one add-on therapy. Do you have core binding factor leukemia, which is translocation 821 or inversion 16, the quote unquote good risk? You may have another drug added to it. And then we get into the adverse risk side. And some of these things, a lot of this may go along with the mutation called TP53. Even if you're young and fit, actually maybe non-intensive options are a best option. Although really for some of these adverse risk groups, we need to highly think about novel therapy again. And we'll hear that detailed discussions, in a moment. So just briefly, I think a lot of times everybody is looking, well, what's the response? What am I looking for? What do all these words mean? This is somewhat just to have as a reference. Again, this is from the updated ELN response criteria. We do try to obtain a complete remission. What that really speaks to is that those white cells that are really low, your neutrophils have now recovered to a safe level above 1,000, platelets above 100,000, and all those bad blasts that we see under the microscope are now at least less than 5%. I think to Dr. Desai, what she would mentioned before is extremely important. So I think where we're going is better and better technology for this minimal or what's called measurable related disease. I like to use my iceberg analogy. What you see above the water are these blasts, and really we'd like to make the whole iceberg go away. And technologies are getting better and better at defining that. And this really may be the most important metric to achieve, irrespective of type of therapy chosen. But then you could have a little bit less good response, just the blasts go away, some level of blood recovery. And so when you hear all these terms, or maybe if you're reading about what's my chance of remission, you'll see a lot of this together. And so just really wanted to give a little bit of a brief discussion, on that perspective. You'll also hear CRH, which is really a high quality response. It's all the counts improving, just less than the level of a true complete remission. A lot of current protocols look at a combination of what we call complete remission and CRH, which again is complete remission with hematologic recovery. So again, outcomes do matter, as far as age, and some of this may be the genetics behind it, what therapies are chosen. You can see really a lot of great strides in patients less than 60, over, let's say this is over like a 5-year over, let's say, a 5-year time frame, where patients, clearly have improved outcomes if they have good risk disease versus adverse risk. That becomes a little bit less separate once you get to over 60. Again, some of that may be what are the therapies that are being chosen, but it's just that one size does not fit all. A good risk mutation in one sense may not always be good risk. And so speaking to that, just to give you one example, NPM1 is historically, and if you go back to that ELN chart, it's considered good risk, especially if it's without a FLT3 mutation. But if you look at these survival curves, so basically if it goes lower, like the blue line, that is worse. So these are all patients with NPM1, but clearly if you were 55 to 65, you did much better than if you were over 65. And this was in patients that all got the same type of high dose therapy. And this really may speak to the fact that maybe there's not just NPM1. Is there other things going on that may make higher risk in that setting? So again, one of the importance is we really have to personalize our prognosis discussion and treatment selection, not just based on age, but based on biological factors as well. So I won't go into this. This was, I think, detailed nicely by Dr. Desai. Again, there's a lot of technologies. These are evolving, continuing to be of higher depth, continue to be fancier, even to be able to look at a single cell and say, hey, what mutation does that cell have versus another one? This may help when we start thinking about targeted therapy and how patients respond, or how may potentially other patients, don't respond. And I think a lot of times what we're going to be thinking about is actually treating. So, historically, if you're in remission, that's as good as we could get. I think now the standard of care is going to start to change, whereas if you have low-level disease or this MRD disease, we're going to try things, maybe use of agents that we currently have, although a lot of this may be focused, again, more on what Dr. Caraway will mention in a moment. So I'm going to jump through some of this. So just to speak to how important this is, again, just from a standard of care perspective, this is looking at NPM1. Again, this is the most well-validated gene as far as looking at MRD, but there's a lot of data, not just utilizing regular sequencing, but flow, comprehensive sequencing, where you look at a lot of genes all at the same time. But if you're red, it means that you still have that tiny amount of disease. Your chance of relapsing is really high. 70% to 80% of these patients or higher will relapse. Whereas if you're negative, maybe then those patients are that group of patients that can be cured. So can we spare people from needing transplant? Can we spare people from needing other therapy? Although on the flip end, if clearly it's positive, well, we really need to think about what can we do in that setting. Again, whether or not it's utilizing agents, some of which may be off-label, or thinking about trials. Again, MRD is highly tied to how our patients, are overall doing. And just to give a little bit of even with a non-MRD technology. So we kind of looked at this with just standard sequencing. This is something that's commonly done for leukemia patients on blood or bone marrow. And we wanted to see, does this predict outcomes? But really what, is tightly concordant with how people are responding. So if you look at patients that have complete remission, if you see all these dotted lines go down to 0, means that the mutations were now gone, which is what you would expect. If you're getting a good response, these bad guys should go away. But if we look at, hey, well, what about these 2 patients? They actually still had, high, mutation levels. Actually, one patient actually increased even when they were remission. Well, actually, both of these patients ended up ultimately progressing relatively short after that. So again, it's a high predictor, even when we're not using sort of ultra-sensitive techniques. Whereas if you look at patients with relapse, not unexpectedly, really all patients have some level of mutation. So now jumping, well, what treatments are we utilizing? Again, historically and still now, if you're younger and fit, again, what is younger? I think that's a tricky question. But we do think about high-dose chemotherapy, which is a combination of an anthracycline, either daunorubicin or idarubicin, in combination with cytarabine. This is what you'll hear of called 7+3, where again, one of the drugs is 3 days, one of the drugs is 7 days. I think even this, we've been optimizing. What's the right dose? Which is the right drug? A lot of this may be a little bit physician preference, but there has been tweaking that has improved outcomes. Somewhere between on the higher side of the anthracycline is probably better, but it's just probably as good as we're getting with this traditional backbone. But again, even with that, you'll get some disagreements amongst the community, like what's the best dose? Again, this is probably a little bit more on the trivial side, but just something that gets discussed. So what are we adding on top of that? Again, the goal, at least my goal a lot of times, is not almost ever to give just 7 and 3. If we're going to use it, is to add on something else on top of that. So Midastorin is an inhibitor that inhibits FLT3 and other pathways that help these leukemias survive. So this was the trial that led to its approval because it improved survival, and it didn't matter if your FLT3 was high or low. And so this is currently a standard of care. There is a question, and I think we'll hear more about this, are some of the newer FLT3 inhibitors, which are some, one of which is approved, and I'll mention briefly in a moment, but there are others in trial. Can we improve upon that? And there may be subgroups. So again, if you were NPM1 mutant and FLT3 mutant low, which now falls into this good risk category within ELN, this group did do particularly well, but was probably in the setting of getting midostaurin. And so, maybe this is a group that particularly can do well, and maybe we can avoid the need for transplant. That being said, I'm always a little bit concerned with FLT3 mutations. Another drug is Gymtuzumab. This is a drug that essentially binds a marker on the outside of leukemia cells called CD33 and drops off a payload or chemotherapy to it. I think the point is this has been shown in studies to improve survival in good risk and intermediate risk, which are these kind of 2 curves on the left. So particularly for patients that have that 821 or inversion 16, really a very dramatic improvement of survival, I would argue should be, definitely be standard of care. And other subsets, it's a little bit unclear, but clearly does have some benefit. Identifying what groups may do best from it, I think, is a little bit under active investigation. And there are some safety issues. It can hurt the liver. So we really try to give the lowest dose possible. A lot of patients can actually just get by on getting 1 day of therapy at a relatively low dose. Well, again, going back to those mutations that you heard Dr. Desai, mention, not all patients, you have a 65-year-old, this is a video, classic age coming in at presentation, no history. But when you look at the bone marrow, the cells, some of them look abnormal or dysplastic. And so, but they never had a history of anything before that. Their counts were normal. Is their leukemia really kind of what we call de novo, or, is it more of a secondary type process? And why it matters is because therapies may be different, outcomes may be different. And what this study nicely showed, if you had any of those mutations that are in blue, actually very highly specific that really this is a secondary leukemia. And if you look on how patients do going along with that, whether or not you had the mutation only, so you were secondary type, or you did carry a history, again, of prior MDS to AML, those patients had this similar outcomes, meaning a lower chance they get a good remission and overall a lower survival. And I think why that may be, and I think this is kind of nicely shown here, is that, again, you can have, mutations, and even when you get in remission, if you have these secondary type mutations, those may not go away, particularly with our traditional therapy. And so 7+3 is probably not the best option for that group of patients. So what else can we have? So there's a newer formulation of chemo called CPX-351 or Vyxeos. Basically, it's a nice new package of the older chemo. So it takes both the daunorubicin and cytarabine, packages it in these little nanosomes at a specific ratio, and that may give optimal delivery of chemo. It may bypass some resistance mechanisms. This is the main trial that led to the approval of it. It improved survival versus your standard, and it is relatively a standard of care, again, for fit patients that were had secondary AML or therapy-related disease. The phase 3 trial actually only enrolled patients 60 to 75, although it's approved independent of age. And I think what's exciting about this is kind of a recent follow-up publication, is that even if you got a remission, patients that got a remission on CPX did better than patients that got a remission on 7+3. This may be that there was a better depth of remission, although some of this is still being worked out in both retrospective and prospective studies. But if you went to transplant in remission, they actually, over half of the patients were still alive long-term, which is quite impressive. Remember, this is an age group of 60 to 75, secondary AML, and had really good long-term care. So particularly if you're going to transplant, CPX had good outcomes. Now, it's not for everyone. If patients have had hypomethylating agents like Highdose, Dacogen, or azacitidine and decitabine, does not work as well from a response rate. Actually, several of the institutions on this call have been part of looking at outcomes, related to these therapies. And just briefly, well, what about the non-intensive therapies, or really quickly on P53? The only thing we say is P53 does bad independent of therapy. And overall, you probably are better off with a hypomethylating agent backbone, azacitidine, decitabine, over intensive chemotherapy. This is our preference, even if you're 18 years of age. But the outcomes are still not good regardless. And so we really need to think about clinical trials. And I think we'll hear some of that shortly. So what is our non-intensive standard? We finally had this major breakthrough with recent approval over this post this presentation, which was the phase 3 trial on this paper was published in New England, where azacitidine with a BCL2 inhibitor, which basically blocks a survival pathway called venetoclax, worked better than azacitidine therapy alone, a very significant improvement of overall survival. But it's not, it works differently based on. So if you're IDH1 or 2, really quite remarkable improvement of survival and responses. Whereas patients that had FLT3, that subgroup by itself did not have a statistically improved survival. And patients like P53, it looks like almost no benefit whatsoever. Although responses are higher, the long-term outcomes are not good. So a major change, and this is really a backbone for a lot of what we're going to hear momentarily, and hope we can further improve upon it. Maybe that MRD as we go may help guide us. Just briefly, what are targeted therapies? So again, we'd love to have you have mutation A. We give you a drug that inhibits that mutation. There are really 3 drugs approved in the relapse setting as now. Gilteritinib is a highly potent FLT3 inhibitor. It does work against ITD and TKD mutations. This was the trial that led to its approval. But I think we have a long ways to go. A lot of patients may only get blast down. I think we really want to think of quality of life and improving their counts. Can we utilize this drug earlier? I think, again, we may hear some of that in the subsequent presentation, but it was much better than salvage chemo. This is just a pill you take once a day. It does have some side effects, but is much better tolerated than high-dose chemotherapy. And again, gave us our first option approved in the relapse setting. Again, I do think we have a ways to go to further improve it. The other targeted inhibitors, one is IDH2 inhibitor and aciditib, which again, this was actually approved just based on a single-arm trial. If you get a high-quality response, not unexpectedly, patients do have better outcomes. I think that's not necessarily shocking, but it just speaks to that quality of the response. Similarly, the IDH1 inhibitor is called ivosidenib, which may even have somewhat even more durable responses in a subset of patients. But in both patients, about 40% of patients can have a composite complete remission. So I think, things to dwell on, and hopefully we'll talk somewhat about this in subsequently, is again, that MRD, again, not just that you have a complete remission, but can we further improve upon that with our standard of care therapies, ideally with trials that we'll hear about in a moment. P53, one really unique disease. I would really argue that there's not a good standard of care. Hypomethylating agent is a decent backbone, but we really need to focus on trials because, again, doing the standard of care is not good enough. An average survival of 6 months in that group of patients. I think with optimizing frontline therapy, there's a lot of discussion. And one of the biggest questions is, you have a 60-year-old who's fit. Should we choose the high-dose therapy? Should we choose HMA venetoclax? Both, HMA venetoclax causes great depth of remission. So maybe even though it's quote unquote non-intensive, it may be a better option. To me, that's actually my biggest question, particularly in the frontline setting. As we get to relapse, again, we really need to focus on trials, although targeted inhibitors do give us somewhat of an option. And I'll look forward to the discussion part in a moment.